And one of the reasons I often go to the end is it's just us. I want to first off thank all of you. I know it's been a long day. We're already, far beyond. I promise not to keep you here more than a couple hours. Also to say thank you to staff. So let me start with a couple things I want to run. Much of the, let's call them the lobbying, the expert community, you've been remarkably helpful to us in understanding the complications of a managed care model, capitated, those things. There are some bad actors. If any of you are the lobbyists for whoever is buying the MAGA influencers to basically attack anyone who's trying to understand the economics within MA, please understand we've asked the lawyers to start investigating is this unregistered lobbying, and we're going to find out who's paying for it. So just if anyone's watching, please understand you started it, we're going to end it. All right, can I walk through a handful of things? First, let's just get it out of the way. I have a series of articles that I'm going to put into the record, and because I get to not object to myself, you've all probably followed the 7-part Wall Street Journal series that walk through even people in Arizona that were diagnosed with diseases, except they were never treated for them. And the plan always said, well, we hired a contractor to send people's homes. We paid billions of dollars in diagnosis. This is the upcoding problem, our risk adjustments problems, the going at those who ask a question. And some of it just continues and continues and continues. And we even had a couple members talk about the Wall Street Journal article about those who are actually getting their health care from the VA, but somehow still sitting in Medicare Advantage. We've also have articles, and we're actually looking into those when it's a push-off to force someone who starts getting near end of life, and it's part of a MA plan, and to force them into fee-for-service for hospice care, and trying to now chase down some of the odd numbers there. You've also seen the articles that on some of the brokers and the investigations going into there and the false claims that appears to be coming. But why are we doing this? Why are we having parts of this conversation? Here's some of our math, that in 7 years, Medicare is supposed to be, now this is full Medicare, this is the whole plethora, $2 trillion. We go from functionally $1 trillion this year in 7 years to $2 trillion. Some of that's demographics. Actually, it's mostly demographics, healthcare costs, the peak of the baby boom moving into much higher utilization years. I get some math problems trying to make this all work. And so we're trying to figure out, I think, the concept of a managed care model that helps our brothers and sisters who have moved into their benefit years live healthier. When I'm seeing data that 31% of Medicare is diabetes, and then when we broke down the subsets of that, the number of our brothers and sisters who are 65 and up that had obesity issues. How do I incentivize a model, particularly if our math is 55, not 54, 55% of our brothers and sisters on Medicare Advantage across the country, some places higher penetration, that there's an incentive for a plan saying, we benefit by making our members healthier. So this is, from my opening statement, the alignment of incentives. One of the reasons I have great fondness for Dr. Miller is he's been very kind enough to testify in front of our Joint Economic Committee. And in that, we were fixated on the use of technology to also lower the cost. So first question before I go off on some of the things. Dr. Miller, first let's just go where we were going to go before. If I came to you and be a little utopian, said, okay, we have the technology today that follows you around, that the AI transcribes your notes. Here's my doctor's notes, here's my healthcare contract, whether it be private or an Advantage plan. The AI can say they match, and it's basically automated or pre-authorization. Am I being too utopian?
I think it's operationally possible. I think that the issue is, does the industry have the willpower to do this, and then will the hospital industry come to the table? Because one of the other issues is that if you're an incumbent large health system, you don't have an incentive to improve operations. If you're a hospital executive and you can lobby to increase Medicare fee-for-service rates, you can merge with a larger health system, you can do all these other things before coming to the table to improve clinical and technical operations, I think that's an incentive issue. So I think we need pressure on the health systems in conjunction with the managed care industry to work together to solve these technical problems, because they are very solvable.
Doctor, so you think the brain trusts like us, we need to be more prescriptive in our expectation?
I don't think prescriptive. I think it's sort of like when you have two squabbling children, the answer is stop fighting over the Matchbox cars and learn how to share. So I think you have the hospitals and you have the health plans arguing, and you have the plans saying, I have big monopoly hospitals, and then you have the big monopoly hospitals saying, I have these big, mean monopoly health plans. And sometimes they're monopolies and sometimes they're not, but they need to figure out how to work together for a better system and solve that technical operational friction, and you all are functionally their parents.
Dr. Miller, one thing, I want you to touch on how you would adjust Stark to accomplish one of your goals.
So I think that's really important. If you're a physician, and I mentor and train a lot of young physicians, you don't really have any employment choices. You face a labor monopsony where you can work. And I remember I saw this dermatologist who was depressed, and I asked him why he's depressed. And he said, well, he had two large health systems that he could work for, and he couldn't do anything else, and he was stuck on an assembly line. So Stark Law was created to address valid concerns about induced demand, that if physicians own and operated integrated care delivery, that they would self-refer and drive a lot of unnecessary services, whether it's imaging, whether it's labs, whether it's home health. And so we have an opportunity now, with Medicare Advantage being half the marketplace, to waive Stark, because you have health plans who are doing utilization review and prior authorization to make sure that the right thing is done, because it doesn't make sense for us now to say that if you're an orthopedist and you work for a large health system, the health system can require you to self-refer for physical therapy and MRI. But if you're in private practice, that orthopedist, you cannot self-refer for MRI or physical therapy for integrated care delivery. So we need to put private practice physicians on an equal platform to large multi-billion-dollar health systems, and managed care is our vehicle for us to do so.
Dr. Jain, your written testimony, actually, this is going to sound odd, provided me some joy, because in many ways in there you have much of the model that we've been trying to move back, not reform to. In some ways, we're just trying to go back to what the original vision was, that the incentive is an organization benefits by our brothers and sisters becoming healthier, and trying to find those steps where, because an enrollee, a patient, a member can stay with you longer, you invest in their future health. In your vision for your organization, because you have lots of data points, do you see a place where you could also use things like, grandma gets a Whoop, or an oral ring, or the wrap that sits as a wristband that actually helps you monitor hypertension and temperature and those things? Is there a place where the continuity of care, particularly for your rural, we had a whole conversation about transportation and those things, but not telehealth, digital health, in many ways is the future on helping the maintaining of latitudinal health data. Is that woven into, or do you see that
I think
as
it's
part of your
absolutely
plan?
possible. I think one of the reasons that value-based care has largely been a failed experiment in this country is that it can't be practiced in one-year increments. If I don't know that you're going to be my patient a year from now, 3 years from now, 10 years from now, I'm not necessarily going to make the rational investments in year one to improve your health in year 3 or year 10. And so I think one of the opportunities that the committee has and that Congress has more broadly is to start to entertain this notion of multi-year enrollment in Medicare Advantage. Multi-year enrollment would enable us to have stability of the population, which would allow us to integrate these digital health solutions in year one that ultimately have really failed to improve population health, even though we have very sophisticated technology right now, because people are underinvesting in these technologies because they don't necessarily have the confidence that investing in year one will result in savings in year 2, 3, 4, 5, and 6. If plans had a longer period, plans or even CMS in the traditional Medicare program had a longer term view of cost and had a way of internalizing the savings, I think there would be incredible momentum towards the kind of healthcare system that you're imagining, Mr. Schweikert.
Doctor, you may be about to become one of my best friends, which is a little creepy. You never want a politician as one of your best friends. We're expensive. But look, we've been trying to model the concept of what happens if I have someone who has multi-chronic conditions or BMI issues. How do I help them and then, but make it so it's rational to invest in it and then help them stay there? And that's, look, that's not partisan. That's just investing in long-term healthcare. But one of the issues that's been brought to us by actually a handful of the plans that have been remarkably good at working with us and providing us actually some very private data. We've made some promises not to say some of the things out loud, is the way the advertising and broker when open enrollment is of how you're often trying to steal each other's members. We saw a number, and we're still working to vet it, that the total advertising, broker, marketing could be as much as 20% of the book. Does that number seem rational to you?
20% seems high, but what I will say is that the number one line item, the G&A line item for most plans is distribution. So if there were ways to actually cut our overall distribution costs or recast the distribution costs to be more focused on health promotion behaviors.
But investing in actual health care instead of late night cable television.
We have a proposal that we've put forward, which is the notion that brokers should be recast as community health workers. These tail commissions that we pay folks, several $100s a year, should be reoriented around making sure that older adults get primary care appointments, they get their colonoscopies, they have someone in their life.
But that would be within the plan once you're enrolled. But Dr. Miller had actually sort of the other side saying, look, if I have the data set that says I could do fee for service, I could do a combination here, I could do, and see it all right in front of you. The technology is your educator.
Dr. Miller is 100% right. The front door to the Medicare experience is one that needs to be totally rebuilt. Turning 65 in this country is very complicated. And it's one of the reasons that I think people are very confused and don't know what to do, is because there isn't a lot of transparency. It's because you have to sign up for Medicare, you've got to sign up for Part B. It's an alphabet soup for the average older adult who feels paralyzed in the face of the decision making. And I think, I'm not a Republican or a Democrat. I tell people I'm an effectivist. I believe that we need.
Oh, so you're starting another party with Musk?
No, not at all, not at all. But what I would say is, I really want our programs to work the way that they were intended to work. Yeah. And I think that that's where our focus should be right now.
Look, at some point we have to deal with the reality, and this is more for staff to hear. Our current model says in 7 years, the Part A trust fund's empty. And there's a structural 11% cut coming, let alone a 24% cut coming to people on Social Security, and we double senior poverty. We have, the scale of these things is stunning amounts of money. It's demographics. We have a shortage of young people, we got much older. So Dr. Bassel, you actually, one of your specialties, you have everything from urban to rural. If I came to you and said, we're going to incentivize the ability to use much more digital healthcare in rural America, is there a way that actually both raises your quality, lowers your cost? Because I can't tell you how many of my doc friends tell me someone came in from rural Arizona and they didn't need to, drive for 2 hours down from Flagstaff to get to Maricopa County. If we had had the scan had been, sent properly, or we duplicate the scan. Like I have a fixation of all MRIs, X-rays, ultrasounds need to be attached to this so they travel with the individual. We think there could be 25+ billion a year just in duplicative scans. But the ability for you to have continuity, more investment in technology, does that solve or at least help your rural issue?
No, absolutely. So we've actually changed EMRs lately to get access to a broader network of electronic records. That interoperability piece is certainly part of that equation. And you talked about digital health as well. So my wife is a pulmonary and critical care doctor, and in a very rural network, probably 15-20% of her patients already are via telemedicine. So if she's in clinic on a given day, her 9 o'clock patient will be in person. Her 9:30 is very likely going to be somebody from 3 hours away that she's seeing via telemedicine, to save that family having to drive that 3 hours.
I want you to think much more revolutionary. Maybe this is more in Dr. Miller's utopian of technology. Staff is telling me they're late for their cocktail hour. We actually, look, I've been doing telemedicine since I got here. It was never, ever going to get a hearing until COVID hit, and then suddenly it's the law, and the world didn't come to an end. And the amount of inbound crap I took in advertising those things, beating me up because but the fact of the matter is the data that I can wear, come off my body, the breath biopsy, all the other things you can have in your home medicine cabinet, that telemedicine may not be talking to a human.
Yeah.
It could be getting my readout, telling me if I need to go to, my doctor.
We're already having steps like that. My watch just told me I need to be getting up and move around.
Yeah, my Oura Ring was doing the same thing. So, look, I cannot thank you enough. We're going to have the continuing sort of debate, and we're digging into it. As you know, the Oversight Committee is doing a deep dive. We're trying to do the data. We're trying to understand, is MedPAC, is this thing correct that I have 120% over the cost of fee-for-service? If that's gap, that gap would be a stunning amount of money over 10 years. We want the continuation of a managed care where the incentives are properly aligned. Help us with any articles, help us with data, and for any of you, thank those plans, those insurers, those researchers who've been positive in helping us, and fuss at the ones that are trying to burn us down for even looking under the hood. And with that, we're going to call the hearing to an end, but please be advised that over the next couple of weeks, you may get written inquiries that we will ask you to respond to, that we will attach to the permanent record. And with that, we're going to call this hearing adjourned.